Hello, everyone, and welcome to Lecture 7 in our course on drugs and behavior. So this lecture is the beginning of the fourth week of our class, and we'll start talking about drug use and its impact on society and the individual. So far we've talked about uh, the history of drugs, going back to ancient history and moving up to almost current times. We talked a lot about the brain, and that sort of lays our foundation for how drugs have their effects. Why are drugs specific to a particular set of behaviors, for example? And so now we're going to build off of that foundation and start talking about society at large, and in particular U.S. society. And from there, we'll move on to things like drug policy, drug regulation, and in a couple of weeks, we'll get into individual drugs and really get into detail on drugs one by one, or classes of drugs one at a time. So for this week, what we're going to do is look at drugs and their effect on society. And of course, society is comprised of individuals. And so we'll begin by looking at the individual. Now, the last couple of weeks, we looked at the brain of the individual. So really looking at even small scale phenomena like how drugs have their effects on individual neurons, individual brain cells. And so we're going to look a little bit larger scale than that now, look at the individual and individual behavior and physiology. And from there, what we'll do is look at how society classifies drug use. So dependence, for example, will be a big topic this week. How do we determine whether an individual is dependent or not on a drug? And how do we understand drug dependence? And there have been a variety of ways to look at that problem. And then, how do drug users affect society? And that's, of course, that's a two-way street. Society, through things like policy, regulation, attitudes, affects individual drug users, but drug users, as we'll see, can also have an effect on society. So in this session in particular, what we're going to do is first learn about individual effects of drugs, again, at a larger scale than we've been looking, larger than the brain, so looking at the whole body. So learning about drug toxicity. And then we'll look at where we get some of our information in terms of drug use. So there are a couple of organizations we'll focus on that determine what drugs are involved in a person's actions or a person's death even, and how do we use that information? What are the strong points of that information? What are the weak points? What are the kinds of information those organizations don't provide to us? What we'll also do is learn about larger social consequences of drug use. And we'll start that in this session. Next week, or next session, we'll actually start talking about that a little bit more in terms of things like crime. Uh, this session, we'll talk about one particular aspect of drug use and its consequences, and we'll move on to the bigger picture next time. Okay, before moving on to this week's content, I'll first comment on this last week's discussion questions. So the comments were good. We had a lot of thorough, insightful comments. As a side note, just as a reminder to some of you, the discussion is a required part of the course. So if you haven't been participating, it's a good idea to start doing so. If for no other reason than it is part of your grade. But also the discussions are really interesting, and we've had some really good back and forth. So please do get involved if you haven't been so far. So the first discussion question was about the placebo effect. And in particular, the importance of double-blind studies with regard to the placebo effect. And why do we have double-blind studies? Because, of course, we know that in a study, you'll often experience the placebo effect. You'll have people in the control group that aren't being treated with a drug. They're getting a sugar pill, for example, and they'll report some improvement in their condition. And, of course, we don't want to market and approve a drug that actually doesn't do anything if it's just as good as the sugar pill. So a double-blind study is intended to address that concern. And of course, the point here is to eliminate bias. So participants that know they're on the drug or not may behave differently. If they know they're on the drug, they may exaggerate their experience. If they know they're on the placebo, they will likely downplay their experience. So the experimental subjects all often want to experience the benefits of the drug, or they want to please the experimenter, any number of things. And the experimenter is also subject to this bias. So the experimenter may want the drug to work. Maybe they work for the company that's developing it. Maybe they have a hypothesis. They want to confirm that hypothesis. And so the experimenter is not immune to this bias either. And so the double-blind study, as people pointed out, is there to eliminate both those kinds of bias. If neither the participant nor the experimenter knows whether a person is in the experimental or control group, they can't be biased. And for the experimenter, this bias could be conscious. It could be throwing out data, for example, that don't support the hypothesis. It could be acting differently around the participants, trying to elicit a certain response. But it could also be unconscious. Some behavior in this context could be below the level of awareness for the experimenter. Or maybe the experimenter rationalizes keeping some data and throwing away other data. So this is not always sort of nefarious on the part of the experimenter. It could be entirely subconscious. But as people pointed out, the idea here is to eliminate bias with regard to things like the placebo effect. Another question was about drugs and synaptic transmission. So here, the question was, why do drugs tend to work at the level of synaptic transmission and not at, for example, the level of action potentials? One of the key issues here is the complexity of synapses. And so in synaptic transmission, there are a lot of moving parts. You have parts of the axon terminal that release neurotransmitter. You have proteins in the membrane that take neurotransmitter back into the synapse or back into the presynaptic neuron, a process called reuptake. You have enzymes that break down neurotransmitter in the synaptic cleft. And of course, you have receptors on the postsynaptic side that are waiting for the neurotransmitter. So all those different parts, it's a very complex machine, but the complexity also gives us lots of opportunities for drugs to take effect at various locations. And so the synapse, being such a complex machine, helps in a sense. It helps by giving more targets. It also helps in terms of being more specific, in terms of what step of synaptic transmission we want to affect. And of course, synapses come in a lot of varieties. Action potentials are more or less the same for any neuron, but different neurons release different neurotransmitters. Different postsynaptic neurons will have different receptors. And by having a drug that attaches to one particular part of that process, as it relates to one particular neurotransmitter, you can be a lot more specific. So you'll have fewer side effects. You're not affecting the brain globally. You're affecting a very particular function. So you can affect perhaps mood without affecting movement. You can affect movement without affecting things like heart rate. So minimizing side effects is a big part of this. And that depends on having all those diverse parts and diverse neurotransmitters involved in synaptic transmission. And then the last question was about the basal ganglia and why the basal ganglia are involved both in movement and in reward processing, as they are. And so here the issue is that movement or actions and rewards have an intrinsic connection. As was pointed out, people and other organisms tend to select actions that are rewarding and tend to avoid actions that have gotten them punishment in the past. So the idea of what action to select is very much tied to the reward that's previously been experienced. And then that's the key issue here, is that connection between selecting an action and learning about rewards. And the more behavior one expresses, the more one learns about which actions to choose in the future. Those actions are reinforced. Another important issue here is dopamine. Dopamine is heavily involved in the basal ganglia, and it's a neurotransmitter that is necessary for movement, and it's necessary for learning about rewards. It's sometimes simplified as dopamine is the pleasure neurotransmitter, and it's not that simple. But it is involved in reward processing. And we've known that for quite some time. But it's also involved in movement. So the disorder Parkinson's disease uh, is a result of certain neurons in the basal ganglia dying. And these neurons release dopamine. So Parkinson's patients start having lower dopamine levels. They have trouble initiating movement. Uh, and we've known that for a while, but what's relatively new is the fact that Parkinson's patients also exhibit uh, symptoms having to do with learning, cognitive symptoms. Now, it took us a while to figure this out, but dopamine's involved in reward processing and learning, and Parkinson's patients will often exhibit deficits in these areas. And of course, Parkinson's is often treated by effectively supplementing dopamine levels, by giving dopamine precursors, chemicals that are turned into dopamine. So dopamine is an important player in the basal ganglia and is involved in both movement and reward. Okay, so that was it for discussion this last week. Again, good discussion. Do participate if you haven't been. Also, this coming week, you'll participate as individuals as we have been so far. The week after that, and I'll send an announcement with more details. The week after that, we'll start working in groups. And so you'll work as part of a group. You'll select one of the questions, mull it over as a group, and then make a single post as a group. So you have a more thorough, comprehensive response that hopefully considers multiple viewpoints. So that's coming up. I will let you know when that is and how that works. And just keep that in mind as we move forward in discussion. So looking at drugs in society, first we're going to look at the individual. And again, we've already looked at the brain and neurons. So looking at the individual as a whole is what we'll be doing this time. So we'll be talking more about the negative consequences of drug use in this session. And that's more of what this week is about, is some of the negative consequences. We'll get into the positive consequences later on. But when we're talking about drug toxicity, there are a couple of ways to describe toxicity. Of course, toxicity itself just means the degree to which a drug is poisonous or dangerous to one's health or lethal even. So a distinction that's made is between physiological toxicity and behavioral toxicity. And as your book points out, this is to a certain degree sort of an artificial distinction. Obviously, our behavior depends on our brain, and our brain is a physiological organ. It has physiological processes. Altering the balance of ions in the brain can change how it functions. Altering the availability of certain neurotransmitters, certain nutrients. All these things can affect how the brain works, and that will ultimately affect behavior. But the distinction between physiological and behavioral toxicity, while it is a bit nebulous in certain areas, we can talk about physiological toxicity in terms of what it does to the body. So basic physiological processing that's perturbed as a result of drug use versus behavioral toxicity, which are things like behaviors that normally aren't dangerous, but either become impaired through the use of a drug or become exaggerated. And so these are behaviors. These are products of our nervous system, products of our actions that make the drug dangerous. So physiological toxicity would be something that affects breathing or affects heart rate or affects liver function. Any of the organ systems in the body. Whereas behavioral toxicity would be something like an impairment in memory, or an impairment in coordination, an impairment in judgment. So these are all cognitive processes, and though, as I said, they depend on physiological underpinnings, they're at sort of a larger scale of description. They describe our interaction with the world around us. Physiological toxicity could happen to an individual in a locked room where they couldn't really do anything, whereas behavioral toxicity really involves the interaction with the environment. And again, this is sort of an artificial distinction because it's not clear where one necessarily ends and the other one begins. Behavior depends on physiological processes. But it's sort of a convenient distinction to make so we'll stick with it to a certain degree. The other distinction that's important is acute versus chronic toxicity. And you may already be familiar with these terms, probably are. So acute toxicity is something that happens suddenly. It's quick to begin, it's quick to end, whereas chronic toxicity is something that takes much longer. And usually it takes repeated use of a drug, and often chronic toxicity is the effects of chronic toxicity are present whether the drug has recently been taken or not. So an acute effect of drug toxicity would be, for example, the decrease in heart rate that occurs when someone takes an opioid, a pain-killing agent of a particular type, or an increase in heart rate as one gets with cocaine or amphetamine. As soon as those drugs wear off, the effect wears off. Whereas chronic is long-term. So a chronic effect of smoking, for example, is high blood pressure. A chronic effect of alcohol consumption is cirrhosis of the liver, scarring of the liver. Chronic effect of opioid use are symptoms like constipation. You may have seen recently commercials for that seek to alleviate opioid-induced constipation. So that's a chronic effect of opioid use, even when it's used as prescribed. So again, this is a short-term versus long-term distinction. And you can mix and match these two concepts. So you can have acute physiological, acute behavioral, chronic physiological, and chronic behavioral. And this table from your book lists examples of each kind. So for example, a chronic behavioral effect would be a change in personality or loss of long-term memory. An acute physiological effect would be change in heart rate when the drug is taken. But you can see that there are instances of each kind of combination of effects. Okay, so those are sort of the individual effects of drugs, and as I mentioned, particularly the negative ones. The question is, when we start talking about drugs in society, how do we get our information? So how do we know what drugs are commonly used? And this is important from a social perspective to understand how common drug use is, especially when it comes to drugs that are deemed dangerous. And we'll talk about why drugs are dangerous or not as the course goes on, and that's a topic we'll revisit again and again. But organizations like the Drug Abuse Warning Network, otherwise known as DAWN, and this network, this organization, logs what drugs have been taken by an individual if they come to the emergency room. Now, it's not to say that the drug was the cause of the emergency room visit, although often it is. That's not the distinction that's being made. So it's just whether the drug is present in the person's system. And unfortunately, alcohol gets sort of a free pass in this situation, as does nicotine, because these are legal drugs, at least for adults. If alcohol is taken in combination with these other drugs, then it is mentioned. But otherwise, it gets sort of a bye. But it allows us to look at the number of emergency room visits as a function of what drugs are in the person's system. Again, not attributing the cause, but it helps us estimate how common a particular kind of drug use is. But again, it's filtered by whether the person's in the emergency room or not. So if there's a drug that's really frequently used, but doesn't result or isn't associated with emergency room visits, then that will not be on DAWN's radar, so to speak. So we can see from this table that alcohol is commonly involved in emergency room visits, not to say it causes them, but in combination with other drugs, it's very common. It's the most common drug, followed by things like cocaine, opioids, marijuana. And again, this is looking at a very particular phenomenon, that is emergency room visits. So these are not necessarily estimates of drug use in and of themselves. They're looking at the combination of drug use and emergency room visit. So this is collected by healthcare specialists, professionals, which makes sense given that it's emergency room visits. Organizations like the Centers for Disease Control and Prevention, often referred to as the CDC, also collect data on drug use. And here they're looking at causes of death. So now we do have some assessment of cause. So the drug caused this event, not just was involved in, but actually caused the person's death. And this is particularly useful for drug overdoses. And it may surprise you to know, maybe not, but it surprised me when I learned it, that at least when I was growing up, you hear things about things like cocaine and heroin, the illicit drugs. And you're led to believe that these cause a lot of negative health effects up to and including death. It turns out that the CDC has published research showing that actually prescription pharmaceuticals, and especially prescription opioids, are responsible for a large proportion of drug overdoses. Again, anti-drug campaigns and the media, not that these effects are bad, discourage illicit drug use by describing how dangerous these drugs are, especially things like heroin and cocaine, which were popular when I was in high school and were also perceived as the most dangerous. But it turns out they don't cause all that many deaths in and of themselves. Despite the fact heroin is an opioid, but this study is looking at prescription opioids. Heroin is never really prescribed, at least in the U.S. That is to say, it's seldom prescribed. There are cases. One thing these things don't really control for, though, is frequency of use. So again, we talked about in the first couple of weeks of class, estimating how often drugs are used by people in the U.S. And this is often, this information is often obtained through things like surveys. Again, looking at emergency room visits, looking at deaths, these are very specific events, very specific phenomena to look at. And it doesn't necessarily tell you how common use of that drug is in society at large. If it's relatively safe, then it may be frequently used, but not cause any deaths and not be involved in many emergency room visits. So we have to be aware of the importance of frequency of use when we're talking about drug statistics. So this also tells us something about if we do independently assess frequency of use, now we can start to talk about how dangerous a particular drug might be. So cocaine involved in a number of deaths, a number of emergency room visits, but its frequency of use is actually not all that high, which means that in order to generate that many emergency room visits, it actually must be fairly toxic because in order to get that many emergency room visits with not that many users, the chances of an emergency room visit, the chances of toxicity must be pretty high. Whereas almost everyone uses alcohol at some point, so it's not that surprising that we have a lot of alcohol use coming into the emergency room. So we always have to adjust our the impact of a particular drug in terms of death or emergency room visits by how commonly used that drug is. Something similar could be said for heroin, which is not to say that we should look only at frequency of use normalized data, or that we shouldn't. That's an open question. So if a drug causes a lot of deaths, but is also commonly used, should that be the target of an anti-drug campaign? Or should it be the drug that isn't frequently used, but causes a disproportionate number of deaths? So one is more common and may cause more deaths overall, and the other is less common, but relative to its use is actually fairly dangerous. Which one do we address? There's no obvious answer to that question. I leave that to you, and obviously elements of the media, the government, our society have come down on one side or the other of that idea. But there's no go-to answer. Do we care more about what causes more deaths overall, or which is more dangerous per use? Open question. A quick word about intravenous or IV drug use. One of the most important side effects of drug use is a behavioral side effect, and that is the threat of bloodborne diseases. And this was very important when I was growing up, for example. So spreading things like hepatitis B, and in my childhood, the spread of HIV. And actually, one of the things that's been interesting to see as time has gone on is that people don't talk about AIDS as much as they used to, as they did 20 years ago. Now it's mainly about HIV. And the spread of HIV, when I was growing up, a lot of it was through the sharing of needles by IV drug users. Now, thanks to media campaigns, that has gone way down. But now HIV is primarily spread sexually. But at the time, it was IV drug use was a big cause of the spread of HIV. Also, as I said, it's the term HIV is used more commonly than AIDS. AIDS, of course, is the advanced stage of HIV infection. It's so that people don't spread AIDS, although that was the way it was described 20 years ago. People spread the HIV virus, and then AIDS is a consequence of having an HIV infection. And now part of that, part of the reason for the change in terminology is that AIDS, the concept became stigmatized. And so in order to avoid that, in order to have a more open discussion, in order to not not force people with HIV to go into hiding effectively, um, the need was there to destigmatize HIV and AIDS. So that term has gradually transitioned. Also, with more effective treatment, it's now very likely, in fact, that someone will have HIV without developing AIDS, whereas 20 years ago, having HIV was almost inevitably going to lead to the person having AIDS. Anyway, so HIV, hepatitis B, these can all be transmitted through IV drug use. And so one of the big consequences of drug use, of intravenous drug use, at least historically, was the spread of bloodborne diseases. So that's a social effect. So now we're talking about more than just the individual. Now we're talking about society. And one of the ways that was devised to address this issue was the concept of needle exchange programs. And this is a method by which an IV drug user could bring in a needle they had used and exchange it for a clean one they could now use. And so they could get free needles, free clean needles, and wouldn't have to keep on trading, keep on swapping used needles back and forth. Again, the point being to decrease the spread of bloodborne diseases by providing clean needles. Now, there's always been some opposition to this. The idea being that by giving out free needles, that these agencies would either be encouraging or at least not discouraging intravenous drug use. That we would end up with more IV drug users because we were giving out free needles. The evidence doesn't really bear that out, and this has been going on for decades now. And so, and certainly the spread of bloodborne diseases by IV drug users seems to have declined significantly. So this is one of those examples that I think fairly unambiguously has been a positive. So it doesn't seem to increase IV drug use, but it does significantly decrease the spread of bloodborne disease. So it's sort of a win. Okay, so that's going to wrap it up for this session. Next time, we're going to continue our discussion of drugs in society. So this time we talked more about the individual and started getting into society. And next time we'll talk more about society at large. And we'll talk about things like models of drug dependence. So how has society and psychological and medical professionals in particular, how have they approached the problem of drug dependence? So how do you describe it? How do you define it? When is someone dependent on a drug? What causes drug use and drug dependence? So if we're looking to diminish use of a particular drug or misuse of a particular drug, we need to know what the causes are first. And then finally, given the phenomenon of drug use, how is it related to impact on society? And in this particular case, we'll talk about crime. How is drug use related to crime? Does it cause increased crime? If so, why and how? So those are all topics we'll talk about next time. So I will see you then.